Anterolateral impingement can commonly occur, particularly in patients who have had a history of multiple sprains. We ruled this out using Malloy's test as shown here. So all we're doing is putting our thumb in the anterolateral gutter and we're dorsiflexing the foot and looking out for any reproduction of pain or symptoms. And again, this was negative. So we're ruling that out. And remember that this test has got high sensitivity, so we can be pretty confident in our outcome there. I think with patients with a history of multiple sprains, it's always worthwhile looking at the calcaneocuboid joint. And we palpated around this region, palpated the cuboid both dorsally and from a plantar direction, but also looked for any instability or reproduction of pain in a varus foot test. So here we're just stabilizing the rear foot, ensuring that we're not moving the subtalar joint and we're pulling the mid-tarsal joints into internal rotation and inversion. And again, this was negative. So a healthy calcaneocuboid joint in this case. We were more concerned that some of the pain was coming from the peroneal tendons, which can commonly associate an acute ankle sprain. When we palpated this region, there was some pain. Also, it's important to be mindful that if it's a higher grade sprain, that there is a chance that they could have damaged the peroneal retinaculum, either superiorly or inferiorly. Now, we had a low suspicion of this, given that the X-ray was clear, and in higher grade tears of the superior peroneal retinaculum, there is sometimes a flex sign that's reported on the X-ray. It wasn't in this case. And whenever we got the patient to circumduct or undertake resisted eversion of the ankle, the peroneal tendons remained where they should in place. Here's an example of somebody who had a full high-grade tear of their superior retinaculum. So whenever they're everting, you can see the peroneal tendons almost dislocating anteriorly. So they're not sitting within the peroneal groove. But thankfully in this patient, we didn't have to worry about that as a problem. The other thing that we're thinking when patients are presenting with instability and multiple recurrent injuries is whether or not there is any damage to the joint surfaces. We know that the prevalence of joint injury, particularly osteochondral lesions, increases the more sprains that somebody has and can be as high as about 1 in 3 in people with chronic ankle instability. The most common place to get this is the medial side of the talar dome. And that makes sense because if you've got a supination injury, you open up laterally and you compress medially. Now, there isn't a very accurate clinical test, so we had to just rely on the patient's pain behavior, the fact that the joint wasn't obviously swollen, and that they didn't have pain around the talus and around the talar head as far as we could see. So we were quite confident at ruling out any damage to the osteochondral area, but we're mindful of some of the limitations of our clinical test.